Yeah, thank you very much. And I really appreciate this invitation. Obviously, asymptomatic moderate aortic stenosis is a hot topic in these days. So the topic of my presentation, future expansion of TAVR, asymptomatic moderate aortic stenosis, what is the limit? Those are my financial relationships. Basically, why are we tackling those problems? Mild, moderate aortic stenosis, the reason is here. There's a big gap between 4-year treatment rates with aortic valve replacement and mild to moderate and moderate aortic stenosis and 4-year mortality. That's a big gap, and we wanted to close this gap now that we have TAVR available. This is the established paradigm. The moment of intervention is really with the onset of symptoms, as we know, and we've all seen this graph from Braunwald. The current management of severe asymptomatic aortic stenosis summarized here follow every 6 to 12 months for symptoms, either spontaneous or exercise. If it remains symptomatic, look at ejection fraction with a cutoff of 50% and markers of rapid progression to symptoms. On asymptomatic severe AS, recent additional lessons from surgery, early intervention is superior to careful supervision, as shown here in the recovery trial and the Avatar trial, 150 patients around. But supervision is inferior to surgery. The news for TAVR in this asymptomatic severe patient cohort is summarized on this slide, early TAVR trial and Evolve trial. We all know the early TAVR trial at the asymptomatic aortic stenosis assessed by negative treadmill test randomized to transfemoral TAVR and SAPIEN. To clinical surveillance, the primary endpoint is superiority, composite of all-cause death, stroke, or unplanned CV hospitalization, a minimal follow-up of 2 years. The Evolve trial is really very special. It is a cardiovascular magnetic resonance looking at fibrosis that are not caused by myocardial infarction. These are the results that we all heard at the late breaker at TCT, a very positive trial of early TAVR, as we can see here on this graph. And the Evolve trial is not positive, as you can see on the right side. This is the symptoms of early TAVR and conversion to aortic valve replacement. In red, advanced signs and symptoms, and in yellow, progressive signs and symptoms. The majority of patients had dyspnea, dizziness, or fatigue. Only 10 patients in this group had syncope. So in summary, in patients with asymptomatic severe AS, a strategy of early TAVR compared to clinical surveillance resulted in a significant reduction of the primary endpoint, was not associated with excess mortality or stroke, prevented a clinically meaningful decline in quality of life in clinical surveillance patients who subsequently converted to aortic valve replacement, improved measures of LV and LA function. The strategies of preemptive TAVR or for severe asymptomatic AS is safe, with no excess hazard related to early intervention, reduces early hospitalization for progressive symptoms or urgent treatment, and may reduce stroke through mechanisms that merit further exploration. So what are the clinical implications? Obviously, watchful waiting is no longer appropriate. Earlier diagnosis and preparation for intervention is needed. Educational initiatives across referral networks have to be established, and obviously the guidelines have to be updated. Moving on to moderate aortic stenosis, we all know from various studies that this is not a benign disease. As you can see, moderate AS, not an innocent bystander. Here the data from Australia. We have seen this slide before, and on the right side, United States. And the rationale for unloading the left ventricle with an EF cutoff of 50% is summarized here. The death below 50 is increasing 16.5 to ejection fraction higher than 50, 4.2. So there is a rationale for unloading the left ventricle. The heart failure reduced EF requires medical, neurohormonal modulation, and afterload reduction. The treatment of moderate AS may represent a complementary target for afterload reduction. These are the load principles between AS and heart failure. You see heart failure, increased afterload to sympathetic activity on the right side, increased afterload due to aortic stenosis, and both together, the coexistence of those both might lead to a bad outcomes. Let us be reminded, what is moderate aortic stenosis for a good ventricle may actually be severe for a depressed ventricle. TAVR unload trial design, transfemoral TAVR versus CAS. We don't need to discuss the limitations of this trial, but there were significant limitations. Here, TAVR versus CAS. We also know the major events between here summarized MACE and all-cause death. And here the competing risk analysis of this trial at 3.5 years, patients were either dead or had received TAVR. 43% of clinical surveillance group underwent TAVR, mostly because of progression to severe aortic stenosis. So, moderate aortic stenosis with heart failure is well tolerated by a good ventricle, but poorly tolerated by a failing ventricle. Moderate AS with heart failure is associated with poor prognosis. There is no indication for replacement in patient with moderate aortic stenosis and heart failure unless they have an indication for cardiac surgery. Closer clinical echo follow-up every year at least is recommended for at-risk moderate aortic stenosis patients. Asymptomatic and moderate aortic stenosis clinical takeaways summarized learnings from the new evidence. Rather sooner than later, TAVR will be indicated or needed. TAVR needs to be provided swiftly after symptom onset to prevent mortality risk. Early intervention is safe, no signal of harm. Implications for clinical practice: as soon as severe asymptomatic AS is diagnosed, full workup, including CT and game plan mandatory. Center should be able to provide timely intervention after symptom onset. Open discussion about patient preference. Moderate aortic stenosis, learning from the evidence, patients with concomitant heart failure are more complex, clinically challenging subset of patients. Frequent follow-up is mandatory. Then more evidence of the role of TAVR is needed, and there's potential indication of cardiac damage stages that need to be better understood. More evidence is coming and more evidence is needed. In asymptomatic severe AS, DANAVAR and EASY-AS studies are underway or coming. In moderate aortic stenosis, progress AS with the SAPIENT and EXPAND-2 with the EVOLUTE. Basically, the new treatment paradigm, as we all know, the established moment of intervention. When symptoms appear, we have to intervene. Possibly this changes to the latent phase. Supposed sweet spot of intervention, no harm, salvaging mortality risk, and salvaging myocardium is something that needs to be further studied. With that, I like to close and thank you very much for your attention.